Oliva. I was a fourth year here last year. I'm now one of the new attendings. Today I'll be doing a talk, kind of a report in some ways, on my experience at the Psychedelic Science Conference. I attended that when I was still a resident. I was fourth year at the time, last June. It was held in Denver, Colorado, and it was the largest psychedelic conference in the world ever, which was really interesting to see. So going over my, see if this thing, there we go. Going over the overview, I'll be doing a brief history on psychedelic research that was going on before the most recent surge. So in about 12 slides, I'm going to get through about 70 years of history. I'll go into some more recent research and kind of the rebirth of psychedelic research, namely Roland Griffiths, who led the Johns Hopkins research group on psilocybin. And I'll go through some of the studies and reports I saw when I was at the psychedelic conference. A lot of this, when I saw it, that wasn't actually released publicly. Most of this has now been published, but a few of these things I'm going to show you haven't even been published yet. I'll go into public opinion polling regarding Americans' general view of psychedelics, the MDMA-assisted therapy for PTSD, ibogaine opiate use disorder, which actually matters a lot to Kentucky right now, if any of you have heard. Psilocybin and cluster migraine for treatment of cluster or migraine headaches, and then psilocybin and spirituality research, which is kind of unique. And if anyone wants to ask a question or is interested by anything, please feel free to interrupt me. A lot of what I'm going to say might be a little thought-provoking, so please feel free to ask any questions during the talk. So starting off, what are psychedelics? So the actual term psychedelic translates to mind manifesting. It was termed by a British-Canadian psychiatrist, Dr. Humphrey Osmond, who we'll get into a little bit more in a second. Psychedelics include a lot of natural compounds, including psilocybin or psilocin. Psilocin is actually the psychedelic compound. Psilocybin is a prodrug that's converted to psilocin in our system. Mescaline, DMT, other synthetic compounds, including LSD, which I'm sure all you've heard of, and some more rare ones like 2CB and the 2C families. Some people also consider MDMA a psychedelic, although it functionally is very different than classic psychedelics. And this is the chemical structure to LSD right here. So what do psychedelics do in our brain? So most psychedelics activate 5-HT2A and a few other serotonergic receptors. It seems the majority of its activity, though, is on the 5-HT2A receptor. However, recent research has also shown that they actually activate TAR1 receptors as well. And if you ever talk to Dr. Malik, there's a lot more growing interest in TAR1 receptors and what that has in consciousness. This brain imaging study you see here was done by the Imperial College in the UK, Britain, not Kentucky. As we'll see in a while, a lot of the research on psychedelics was actually done outside of America for several decades. But this study was looking at what LSD actually does on our brain activity. And it showed that on a macro sense, LSD actually decreases activity in the medial prefrontal cortex, as well as the posterior cingulate cortex. So it's kind of surprising because people thought like, oh, psychedelics, probably increase your brain activity, but it actually shows that using them actually decreases brain activity in your cortex. And we'll kind of get into why that is. People report feelings of euphoria or anxiety on them, tangential thought process, somewhat akin to a mild psychosis, or severe psychosis if used too much, but also pro-social behavior, as in more social togetherness and social cooperation, as well as a loss of ego. And that probably makes sense why people's ego or cortical functioning is reduced, because it actually reduces cortical activation in your frontal lobe. Physical effects include increased heart rate, mydriasis. They kind of act like a mild stimulant in a way. A mild increase in blood pressure. People also report visual hallucinations, and visual hallucinations tend to be more like wavy patterns, not full-on hallucinations like seeing new figures, or synesthesia, or combination of senses. So people can sometimes hear music or taste music, which is kind of interesting. So going through the psychedelic history, starting from prehistoric history, we know that different indigenous groups used natural psychedelics for centuries in various religious and spiritual practices. Many still do to this day. The the Native Indian Freedom Act of 1994 actually protected psychedelic use for Native American tribes in America for cultural, spiritual practices, actually, which isn't well known. So there's still Native American tribes, mostly out west, who still use psychedelics like psilocybin and mescaline on a routine basis for their religious practices, and it's completely legal in America. A lot of the different psychedelics used include mescaline and psilocybin in Central and North America, like I mentioned, ayahuasca, which is DMT in Central and South America, ibogaine from the iboga tree in Central Africa, as well as there is some reports that psilocybin was also used by Nordic cultures during the medieval ages, although the level of psilocybin use is kind of controversial, whether it was like more of a regular cultural practice or just a regular recreational use is still kind of unclear if you actually look at the sociological research. But psychedelics have been part of human culture in a lot of different cultures for centuries. Looking at psychedelic science, it really started in the 1940s. So the first synthetic psychedelic LSD was synthesized in 1938 by the Swiss chemist Albert Hofmann, although he actually didn't discover the effects of it till 1943 when he accidentally gave himself a megadose by accident when he was rummaging through his chemicals. Once he did that, he started to have a pretty profound experience, and that's how he found out that LSD could cause give psychedelic properties or effects. It's kind of a funny story if you look further into Albert Hofmann. He was at work in Switzerland during World War II, and because it was Switzerland during World War II, they had a lot of air raid signs going off. Even though Switzerland was neutral, Switzerland was still accidentally bombed by both the Nazis and the Allied forces intermittently. So he was at work, he was having a pretty significant trip, and one of his lab assistants had to drive him home on a bicycle because cars weren't allowed because there was an air raid going on. So you can only imagine how crazy that must have been, unbeknownly going through the first psychedelic trip on LSD ever while going through an air raid. After Dr. Hoffman discovered the effects of LSD, he actually opened up a lab and started producing it for medical research. It was kind of taken over in some ways in North America by Dr. Humphrey Osmond, who I mentioned earlier. He was a psychiatrist who was practicing in Canada, and he started using LSD as well as mescaline for assisted therapy in alcoholism in the 1950s. Dr. Osmond reported, this is his own report, so it was never verified, that he treated over 2,000 patients with severe alcoholism, and about 60% of them wound up maintaining sobriety, which is a very significant percentage. Because of Dr. Osmond's reports, several people in popular culture became aware of Dr. Osmond's treatments. The playwright Aldous Huxley, who was fairly famous at the time, started writing about it in popular media, as well as Bill W., who's one of the co-founders of Alcoholics Anonymous, actually endorsed LSD for the treatment of alcoholism in the 60s, or sorry, in the 50s. As a result, psychedelic therapy began to boom in America. There were these pop-up clinics that opened up all across America, primarily on the coasts, but really everywhere, for treatment of mental illness with LSD. It was very much a component of therapy, especially psychoanalytic therapy, because again, psychedelics kind of get rid of your ego or your conscience, so it worked very well with psychoanalytics at the time. And it became very popular in popular media to talk about psychedelics and how it's coming this new thing in psychiatry. So at the time, there was actually a lot of hope and a lot of positive feelings around psychedelics. At the same time, academic groups started looking at different psychedelics. Probably the most famous and notorious of the groups were the Harvard Psilocybin Project. These were led by two Harvard psychologists, Dr. Timothy Leary and Dr. Richard Alpert, who began publishing extensively on psilocybin and psilocin in the 50s and 60s. Two of their more famous experiments, two of which you may have heard of, are the Concord Prison Experiment and the Good Friday Experiment. The prison experiment was involved using psilocybin-assisted therapy on a prison population. And in that prison population, the recidivism of the prisoners actually was reduced after release by 40%. The natural recidivism in that particular prison, Hartford, was 60%. And in the cohort that was studied, which was about I believe about 50 different patients or 60 prisoners were studied, their recidivism after a 6-month follow-up was reduced to 20%. They also did MMPI testing, and they showed in the MMPI results that their antisocial tendencies was actually significantly reduced by the psilocybin assisted therapy. Also, the first double-blind study was ever done with the Good Friday experiment, looking at psilocybin as an entheogen. Entheogen is basically a chemical that produces spiritual feelings or spiritual sensations in people. So the Good Friday experiment was double-blinded. They took a group of Harvard seminary graduate students, gave half of them psilocybin, half of them niacin, and then did a follow-up questionnaire after their trip, asking what are your spiritual beliefs now, or how are they affected by this experience? And the seminary students who had taken psilocybin reported a very increased sense of spirituality, connectedness with humanity, as well as belief in God, actually, from this experiment. However, I said the Harvard group was very notorious, and there's a lot of reasons why, and there's good reasons why. Several professors at Harvard began raising ethical questions regarding the use of psilocybin on human subjects, especially students. A lot of graduate students, especially graduate students in the Good Friday experiment, felt somewhat pressure to take psilocybin, and that their grades or their standing in the university could be effective. They didn't willingly participate, so they felt very coerced. Leary and Alpert also kind of developed a reputation for just giving psilocybin away because they had a very large quantity of it. They were growing it at the university, and this created somewhat of a black market around Harvard, which caused several issues on the campus. Probably most concerning from an academic perspective was that both would take psilocybin while conducting their experiments. And this likely very significantly affected their own personal bias and led to a significant halo effect with their studies. As a result, due to all these concerns coming up, Alpert and Leary were both fired from Harvard in '63 with cause, but then they continued their experiments and recreational use and began talking about this more publicly with the public media, which kind of gave it a bad light. And their studies, which at the time involved even less academic rigor than they did at Harvard. I should also mention MK Ultra, which was a lot of you may have heard of, kind of cloaked in a lot of secrecy. It was a CIA project from the 50s to early 70s, utilizing LSD as a possible interrogation or mind control drug. The CIA, obviously this is during the Cold War. We were dealing a lot with the Soviets and, spies. And the CIA thought, one, could we use this drug to flip spies to our cause, or two, control people to get inside the Soviet government? The CIA, though, did this very, for lack of a better word, highly unethically. They would first pick societal outcasts, usually sex workers, mental health patients, or homeless people, and would dose them without their knowledge and just observe their behavior. Later, they would dose them without their knowledge and then bring them in for interrogation to see if they could have a mind controlling effect. And these were done on American citizens in America. LSD was also later trialed on military personnel, some more willingly, but again, than the military. So if they refused, it could have had repercussions, as well as possible Soviet spies that were caught. However, the studies actually proved to be pretty fruitless. They found that the interrogation and mind controlling effects of LSD were very variable or non-existent. So eventually the project was abandoned. However, because they were illegally testing on American citizens, the CIA director at the time ordered most of the information on it destroyed in the early 70s. So we really don't know the extent of how far they went. A lot of these reports are from former participants who came out publicly, or whistleblowers in the CIA. So all this kind of led to a decline in psychedelic research at the time. Recreational use began to become very popular with psychedelics in the 40s or in the 60s and 70s, in part linked to the counterculture hippie movement. And this was actually very much advocated by Leary and Alpert at the time, which didn't help things either, because they were kind of viewed as black sheep in the academic community. Also, uncontrolled bad trips started to come up in popular media, people being hurt or getting psychotic, which is a known effect from taking too much psychedelics. Most notably, the death of Diane Linkletter, who was the daughter of Arthur Linkletter, a popular actor at the time. She was reportedly on LSD, and she jumped out of a 8-story apartment or 6th-floor apartment window and died. It's kind of unclear if that was an intentional suicide or an accidental death. But Arthur Linkletter, since he was such a popular actor at the time, went to the media, was on news shows, and talking about how terrible LSD and other psychedelics were, and blamed them for her death. Also, in the academic community, besides Richard Alpert making everything worse, several academic researchers became aware of the MK Ultra experiments because several doctors were recruited for the experiments. A lot of these researchers didn't want to become associated or linked to MK Ultra, so they refused to do any psychedelic study at risk of tarnishing their reputation. This all led to a chilling effect on research regarding psychedelics at the time. And because because the American government under Richard Nixon started the war on drugs in the 70s, the Controlled Substances Act of 1970 was passed, which listed most psychedelics, including DMT, LSD, psilocybin, and mescaline as Schedule I, saying they had high abuse potential and no medical benefit, despite already some research showing medical benefit for depression and substance use. So as a result, any use or possession of psychedelics became a high-class felony at the time. MDMA also was later added in the 80s as MDMA became a popular rave drug, and also was listed and is listed as a Schedule I. And Dr. Leary basically went off the deep end because he was doing so much LSD on a regular basis. He became very, for lack of a better word, he became almost psychotic at times, talking to the media, had a lot of run-ins with the law. He was arrested several times, not just on drug possession, but also various public offenses, including evading arrest. A funny story, actually, was when he was in federal prison. They were giving the prisoners at the time standardized psychological testing to kind of determine what type of job they should do. It just so happened that Dr. Leary had designed one of those psychological tests himself. So when he was given that test in prison, he gave intentionally pro-social and anti-crime answers to kind of fix the test. So he was given a very low security work detail. And when he was on a low security work detail, he actually escaped from federal prison, which resulted in several more charges for him. So he's a very intelligent man, but his behavior severely hurt the prospect of psychedelic research in America. So this led to something we kind of call the dark times of psychedelic research. There was basically no research done in America during the 70s and 80s on psychedelics. A man named Rick Doblin, at a time who just had his bachelor's in psychology, helped found the Multidisciplinary Association of Psychedelic Studies, or MAPS, in 1986. And their goal was, after MDMA was made Schedule I, their goal was to gradually do research on all psychedelics, but specifically MDMA, to show its therapeutic potential. Because Mr. Doblin, now Dr. Doblin, at the time thought that MDMA had a lot of therapeutic potential. Doblin also was very interested in psychedelic research in general, as you can tell. So he published several reviews of early psychedelic research, including a review of the Good Friday experiment that pointed out several biases and previously unknown facts, including the fact that one of the patients who was dosed with psilocybin wound up requiring a Thorazine PRN because they're getting so agitated. So he wasn't just necessarily pro psychedelics, but he wanted to give a very clear picture on psychedelic research at the time. Because MAPS was a very well organized institution, they eventually got permission by the DEA in the early 90s to do safety testing on animal models with MDMA. And that was really the only major psychedelic research going on in the 90s until a man named Roland Griffiths came around. Dr. Griffiths, who you can see here, unfortunately just passed away 2 months ago, had his doctorate in psychopharmacology and was a neuroscientist at Johns Hopkins. In the 90s, he did most of his research actually on caffeine. He was the first person to show that in a double-blind study that caffeine had physical addictive potential, and who also basically mapped out the criteria for caffeine use disorder. So he was already a very well-established name in neuroscience at the time. In 2006, he convinced Johns Hopkins to allow him to basically redo the Good Friday experiment, but under more scientific rigor. And he published the first academic paper on psychedelics in human patients or human subjects in America in over 30 years. Because of this, he eventually got more rope to do more psychedelic research, specifically looking at psilocybin, and began using it in different patient groups, including palliative care, nicotine use disorder, and major depressive disorder. And because he was kind of re-pioneering psychedelic research, especially at a large institution like Johns Hopkins, this kind of created a second boom in psychedelic research. In fact, Johns Hopkins recently founded the first department specifically looking at psychedelic research, not just with psilocybin, but several other psychedelics such as mescaline and LSD. NYU actually this year founded the second department looking specifically at psychedelics in the country. I should make a quick aside. Dr. Griffiths was diagnosed with terminal cancer about 2 years ago. And despite his diagnosis, he continued working on psychedelic research, and we'll get into some of his new research in a second. Despite the fact that he was on hospice, he actually came to the conference this year and did his last public talks. And I was lucky enough to attend some of those, and I got to ask him a question. I never obviously sat down and talked to him for a long period of time. I didn't know him, but I could tell from just some talking and seeing him interact that you could tell he was a very smart but also very kind man. So his death in October is a huge loss for the academic community regarding psychedelics. At the same time, Dr. Griffiths was doing his research on psilocybin. MAPS under Dr. Doblin has also been doing research on MDMA-assisted therapy for PTSD specifically. They got early approval for a phase 1 trial in the 2000s. They completed their phase 1 trial in 2011 and their phase 2 trial in 2019. And we'll get into their phase 3 trial, which we talked about at the conference. The way the treatment works is very interesting. It's a combination of cognitive trauma-based therapy as well as very Freudian analytics therapy, which is kind of interesting. Someone's dosed with MDMA, it lasts for about 4 to 6 hours, depending on their metabolism. And they undergo therapy for 4 to 6 hours as a result. There's always 2 therapists in the room with them. It always has to be a male or female, male and female rather. And the idea of it is to actually kind of create a Freudian parental bond in a sense, having both a paternalistic and maternalistic figure, which is obviously a little bit unique. But the research they've published so far on it has been extremely helpful for PTSD symptoms. Again, we'll get into more of that in a second. So that's been kind of like the history of everything. Getting into the conference itself, looking at the history of the conference, the first MAPS conference was held in 2011. A few hundred attendees participated. In 2014, there was about 1,000 attendees, and in 2014, there was 3,000 attendees. The 2020 one, unfortunately, was canceled due to COVID, but the 2023 one in Denver was the largest ever, like I mentioned, with over 12,000 attendees. It was quite packed, to be honest. It was also a very unique conference. Like I was saying, I've never been to a conference like this before, may never go to another one like it again. The main focus of the conference was the scientific research, the new studies and initiatives going on in the world, especially in America, with presentations from MAPS, Johns Hopkins, NYU, UC Berkeley, Yale, and other research institutions. They had several popular keynote speakers, including the current governor of Colorado, who's a Democrat, and the former governor of Texas, Rick Perry, who is a Republican, both advocating for psychedelic research, which was kind of interesting, again, that bipartisan combination. If anyone's familiar with NFL football, quarterback Aaron Rodgers was also one of the keynote speakers, talking about using psychedelics to enhance his sportsmanship and athletic potential. I unfortunately didn't get to go to that talk, though I'm sure it was very interesting. There's also a large art exhibition, which was pictured here, involving psychedelic art. There's actually several meditation rooms and several accompanying events like concerts. So in some ways, it almost felt like a party at times, while also having a lot of academic rigor and reporting at the same time. Getting into the studies, I wanted to first start with the UC Berkeley Psychedelic Survey, which was just published public this September. I think it's important for us to understand how psychedelics are viewed by the public writ large, especially in America, because we have to work with public opinion in a lot of ways. It was conducted over the summer in June. They had just compiled their results when the conference happened in late June, so we got to see the results before basically anyone else did, which is cool. It had about 1,500 registered voters in America, and it was done through a combination of online and phone interviews with the margin of error plus minus 2.5%. I'd recommend you look at through all the studies I'm mentioning, because I'm just going through the Spark notes. But here are some of the big points. So the first question they asked everyone is, within the last, I believe this was in the last year or two, have you yourself or someone close to you used psychedelics? I don't think this was in last year. I think this was in basically in lifetime, actually. So apologies for the correction. But in their lifetime, has you or someone close to you used psychedelics? And the reason they framed this as a first degree connection is a lot of people feel very self-conscious about saying, yeah, I did LSD back in college. So they added it as a first degree connection. And they found from this result that 52% of Americans had at least known someone who's done psychedelics that was fairly close to them. Which is interesting, showing that it's much more prevalent than I think a lot of people realize. They kind of asked them to categorize what that use was to the best of their knowledge. Most people categorize it as recreational, although about 40% categorize it as something therapeutic. About a third of them categorize it as something spiritual. And as you can tell, people could put multiple categories. So it could have been recreational, but they may have also viewed it as a spiritual experience. About a quarter said that it was a microdosing level. And microdosing is basically dosing to get an effect that isn't fully psychedelic, but still has some cognitive effects, which we'll talk about a little bit as well. Artistic, a lot of people dosing to make art, or something miscellaneous or something else they couldn't categorize. The part that matters to us mostly is the ideas around regulated therapeutic use. So about 60% of Americans actually supported some legal framework for therapeutic use. They didn't get into specifics yet, saying what specifically do you want, but about 60% of Americans were very strongly supported or somewhat strongly supported some therapeutic use for psychedelics, which is a pretty significant number. It's kind of a super majority. Getting more into the specifics, though, you can see there's kind of a broad range of opinions. The only group that they supported that had very comfortable majority support was for people with terminal illness, which makes sense. If you're going to use anything dangerous, you might as well use it at the end of life. And the idea is using something, if someone's suffering at the end of life, you can kind of use anything to see if it might help them. And there has been very good studies, like I said, published by Dr. Griffiths, looking at easing the anxiety of someone with terminal illness using psychedelics, or specifically psilocybin. A majority of people either very comfortably or somewhat supported you if it was recommended by your healthcare provider. For veterans specifically, veterans are always a very big talking point group in America. We always want to help our veterans. People suffering from anxiety or depression, although the very comfortable number kept going down to under 1/3 here. Survivors of violence or sexual assault, i.e. PTSD, people grieving the loss of a child, obviously people going through a lot at the time. And then barely actually, there was somewhat majority support for people who didn't have a mental illness, but thought it could help them in their general life. However, recreational use, your regulated but non-therapeutic use was actually opposed by a majority of respondents. And interestingly enough, people with addiction or substance use disorder was actually opposed the most, which is kind of interesting because they're actually, like we've talked about a lot, research showing that psychedelics can be helpful for other types of substance use disorders. But unfortunately, it seems that when people ask, do you want to use one drug to treat another drug use, people say no. So something to keep in mind. I want to change topics back to MDMA. It's also known, if you don't know, as 3,4-methylene dioxymethamphetamine. A lot of people don't know that MDMA is chemically very similar to meth. The only real significant difference is the methylene dioxy group, the two red oxygens on the end of the benzene ring. Like I said, MDMA is considered by some to be a psychedelic, but in actuality, it's more of a serotonergic psychostimulant. It was first synthesized in 1912, but somewhat like LSD, we didn't realize that it actually had human effects until the 1960s when someone just decided to test it on animal subjects and then later humans. The way it works is, again, very similar to meth in the sense that it stimulates release of dopamine or epinephrine, but more so, it stimulates release of serotonin. And that's why it's different than other stimulants. Most stimulants are just dopamine and norepinephrine releasing. MDMA is very unique that it stimulates release of serotonin. And that's part of why people think it's useful for treatment of PTSD and other mental health disorders, because this release of serotonin actually creates a very euphoric, giddy effect, in theory, allowing someone to deal with past trauma in a more emotionally healthy way. So, like I said, the MAPS published their MDMA phase 1 and 2 trials earlier last decade. They published their phase 3 trial right when COVID hit. And the problem with their first phase 3 trial was that it was very undiverse. It was mostly white and almost all female. So with their second phase 3 trial, they wanted to diversify the participation more. The study included 103 participants. There was a good mixture of non-white and Hispanic participants. It was still majority female, but less so than the first phase 3 as well. I listed all the exclusion criteria here. As you can tell, it's a lot. The most notable being past psychosis or mania, eating disorders, significant personality disorders, imminent SI, significant past MDMA use. You weren't excluded if you used it once or twice before, but if you had regular use in the past, you were excluded. Any active substance use disorder other than nicotine use, as well as other medical issues like arrhythmia or uncontrolled hypertension. I forgot to also mention here that patients who had a first-degree relative with schizophrenia or bipolar disorder were also excluded. The thought being that there may have underlying risk for a psychotic disorder, and you don't want to activate that by giving them a psychostimulant. Also notably, participants were required to wean off or titrate off their SSRIs if they're on one. SSRIs actually downregulate serotonin receptors, as you should be aware. So if you're on an SSRI and dose MDMA, you tend to have much less effect than if you're off an SSRI. So if participants are on an SSRI for their PTSD or other mental health condition, they had to get off it. The study was kind of a very interesting design. So the way they did it was Participants were randomized, and both randomized groups, either the experimental group that was dosed or the non-experimental group, had to go through three preparatory therapy sessions, similar to the ones I already showed, where there's two therapists, usually lasted for a couple hours. Very much trauma-focused therapy, as well as preparing them to understand the physical effects of MDMA. And then there was three experimental sessions. There'd be the dosed session on MDMA, where they'd be doing the intensive trauma-based therapy, followed by a month off the drug with three or four additional therapy sessions. They found through animal testing that it's safest to dose MDMA every month to remove the possibility of neurotoxicity. So they spaced out each session by a month. Then they follow up, I believe it was followed within 6 weeks for additional testing. So looking at PTSD criteria, you can see from the study that there was significant effect. Because both placebo and experimental group were getting very intensive trauma therapy, it makes sense that both groups showed a reduction in their PTSD symptoms, but the MDMA-assisted group had an even larger reduction, very significantly so, as you can see from here. Going deeper, if you looked at the different subgroups or subgroups of response, the study group had much higher rates of remission, a loss of PTSD diagnosis, so it means they no longer had PTSD, or so that responders lost diagnosis and remission. And remission is actually even more significant than loss of diagnosis, saying that their CAPS-5 score, which is a standardized testing for PTSD, if you're not aware, was under 10 points from baseline, or was under 10 points overall. So they basically were showing almost no signs of PTSD after this session. So almost 50% of the experimental group had a complete remission of their PTSD, with about 86% showing a response rate. This is very significant. Obviously, they weren't comparing SSRIs head-to-head, but SSRIs at best had the 50% response rate to PTSD. This study shows that they have an 86% response rate, so very significant. Just some other notes. Obviously, when it comes to psychedelic research, and this is a theme we see throughout, blinding is a huge issue. Most people can tell if they're on a psychedelic or a stimulant versus on niacin. So several members of the placebo group did drop out throughout the study, probably because they were unblinded, or at least in part because they're unblinded. The common physical effects were muscle tightness, nausea, decreased appetite, and hyperhidrosis. But this was very temporary. There was no significant physical effects after the sessions reported. One participant with a history of unmedicated hypertension had a hypertensive emergent episode during the study, although this resolved after the drug wore off and suffered no significant ill effects reported. And what was very interesting was participants in the experimental arm that had a history of SSRI use actually showed significant improvement in the efficacy compared to those without SSRIs, which was kind of interesting. Obviously, this was a smaller subgroup sample, so the power was lower. But the fact that maybe priming someone with an SSRI, getting them off that, then treating them MDMA may be more effective is very interesting from a pharmacological standpoint, possibly related to downregulating serotonin receptors, then having a rebound upregulation afterwards might increase the effects of then dosing the MDMA. But that's more a theoretical idea. However, I should bring this up, and some trigger warning for those watching. There is a cautionary tale with this. I say this a lot because even like whom interested in the possibility of psychedelic research, we have to realize there is a lot of risk and power and responsibility associated with using these possible medicines. So this was in the popular media. during the phase 2 trial of MAPS in 2015, a participant in the study reported that two therapists had touched her inappropriately. And then afterwards, the participants started having a sexual relationship with one of the therapists afterwards, which is a huge violation of professional standards, obviously. The participant stated that the intensity of the session plus what happened to her during the session made her feel almost psychologically controlled by the therapist. So she felt like she didn't have a choice but to engage in a sexual relationship with them afterwards. And again, this shows you that when you're using a medication like this with someone, they're in a very vulnerable state. And there's a lot of risk with that if the therapist, the doctor, whoever they're working with, is not applying, professional standards of care, more so than almost any other drug out there. So there is the risk with this as we explore this more. I am running short on time. I'm going to get through Iboga and Ibogaine because that applies a lot to Kentucky, but I'll leave some time for questions at the end. So Ibogaine, I think, is something that is very interesting to us specifically. A lot of you probably have not heard of Ibogaine. I had not before this conference. Ibogaine comes from the Iboga tree, mostly located in Gabon in Africa. Unfortunately, you have to kill the tree to harvest the ibogaine from its roots. Ibogaine is a slightly different psychedelic. It works as a mild kappa opiate agonist and NMDA antagonist, somewhat similar to salvia, if you've heard of salvia before. The psychedelic properties, the tangential thought process, and or more specifically, the visual disturbances and tactile disturbances last for about 4 to 6 hours, although the altered thought process, tangential thought process, pro-social behavior, all those things can last maybe a full day after dosing. Ibogaine's been used for spiritual purposes in Gabon for centuries, as far as we can tell. But interestingly enough, around the 1960s, people started reporting anti-addictive properties from ibogaine, specifically off opiates. It seemed that even one dose of ibogaine would, one, stop the physical effects of opiate withdrawal, and two, cause people to stop wanting to use opiates. So this became a point of interest in the research community. Like I said, it attenuates the physical opiate withdrawal symptoms. Several animal studies have shown reduced opiate withdrawal symptoms, and smaller observational studies in humans, mostly done outside of America, show good results in reducing opiate use and causing opiate use remission in a large percentage of participants. Again, these are small objective studies, maybe a couple dozen at most, but very interesting study criteria. Small independent treatment clinics that are basically kind of unregulated but are out there in smaller countries are open across Latin America and Oceania, actually. Although ibogaine is not legal in America, it's Schedule 1. But a lot of Americans will go down to Mexico, Costa Rica for ibogaine treatment to get off opiates, actually. Usually if they come from a very wealthy family or family with means. The main drawback with ibogaine is that it causes significant QTC prolongation. The National Institute for Drug Abuse in America actually started studying ibogaine in the 1990s to see, because it's been widely reported, it helps the opiate use disorder. But they stopped their phase 1 trials because so many participants got significant QTC prolongation. And when I mean significant, I mean significant. It seems that the ibogaine also binds to potassium channels in the heart, and participants with a effective dose of ibogaine can get QTC prolongation over 1,000 milliseconds or 100 milliseconds, which is very significant. Like I said, the National Institute of Drug Abuse was doing studies but stopped due to this. And there's been several reported deaths from torsades due to ibogaine use in treatment clinics because of this as well. The treatment clinics in Latin America, some which I talked to when I was at the talk, reported various protocols for this, including cardiac monitoring during the sessions, as well as pre-dosing with magnesium to reduce the risk of torsades. The reason I think it's important to us to know about this is that you may have seen the news recently that the Kentucky government very suddenly decided to invest over $40 million in ibogaine research. It was interesting because they announced this the week before I left for the conference. They were using the money, they got the money from the opiate settlements from Purdue Pharma and other big opiate pharmaceutical companies, and they're redirecting the funds into opiate use research, including ibogaine. But I was going to the conference, I was just learning about psychedelics, and then this huge news came out from Kentucky, and so when I went to the conference, I told everyone, "Oh, I'm from Kentucky." Everyone was asking me about this because it was big news at the conference. And I had to tell them I'd never even heard of ibogaine before the news came out. But this is something continuing to be explored in Kentucky. There is ongoing discussion about using this money to fund American phase 1 trials of ibogaine for opiate use disorder. It's very interesting because Kentucky is known to be in the forefront of research in America. So this type of research in psychedelics is very surprising. While I was there, I met with the people who were performing the phase 1 trials over in the UK, actually. The company is called DemiRx. They're actually now in contact with researchers in Kentucky trying to do the same thing. The phase 1 trial is still not published, but some of the data, I got some of the data from the conference. They were using, they only had 20 participants using different doses of ibogaine. The 9 milligrams per kilogram is kind of the therapeutic dose of ibogaine needed to reach a psychedelic experience, plus the reduction in opiate use physical symptoms, or opiate use withdrawal symptoms. However, their phase 1 trial does show that at the therapeutic window, a therapeutic dose, you get QTC prolongation around 90 milliseconds. Although no other significant side effects were reported in their participants. The results of the study actually were presented to the Kentucky Opiate Commission last month, and are still being evaluated to see if Kentucky is going to start doing phase 1 trials as well. So I know I only have 7 minutes left. Unfortunately, I'm also doing, not unfortunately, but I'm also doing lectures for the first years today. So I need to get going at 1. I have a few other things I'd like to talk about, but if you want to do questions first, I can come back and do this later if you want. So I guess I should ask, does anyone have any questions? Can you hear me?
We can hear you.
I have one question, and I don't think my video is pulling out. Can you hear me, Arthur?
Yeah, I can.
All right. So one of the things that I was curious about, and I talked with Audrey and Megan about possibly covering some of the other studies that have been done more recently on hallucinogens, but MDMA is a potent serotonergic stimulator through VMAT inhibition. And we talk about hallucinogenics, psilocybin, LSD causing hallucinations due to serotonin 2A agonism. And have you read some of the research or some of the suggested theories on why MDMA doesn't cause hallucinations, or why it doesn't cause the same kind of hallucinogenic trip?
So my understanding is, one, we're still not sure that that classical psychedelics are from the hallucinogenic processes from 5-HT2A. There is growing interest in the TAR1 receptors as well, as maybe that could have some effect. Again, that's not my studies, that's just what I've read in the research on new studies. Why that's not the case with MDMA may be partially related to the fact that it's only serotonergic, you're not getting TAR1 effects with MDMA. And 2, MDMA is just flooding your brain with serotonin. So it's possible that the serotonin system may cancel out some of its own effects. So say, even if the psychedelic effects from LSD are caused by 5-HT2A, if you're also activating other 5-HT receptors, that may negate visual hallucinations. Does that make sense? There may be other receptors that have anti-hallucinogenic properties, for example. That's one theory that I've seen out there. Or it's that it isn't through 5-HT2A, it's from other receptors that the psychedelics are hitting, like tar.
Well, that is very interesting because, you know, I've been listening to a lot of podcasts on this, and there's a lot of disagreement in the community. Several people argue over topics, and, you know, I think humility is the most important thing here because, like you said, these things do a lot of different mechanisms. You know, MDMA also massively increases neurohormonal signaling for prolactin, oxytocin, a couple other hormones in the brain. There is a very interesting theory that involves the heterodimerization of serotonin 2A with mGlu2. So there's a thought that this specifically hallucinogen's ability to cause two receptors to come together, a glutamate and a serotonin 2A, that might cause this. And I think that's the position that Roger McIntyre takes, and also Stephen Stahl. So, you know,
I wasn't aware of that, to be honest. It's very interesting.
But there's a lot of interesting things. I always like to hear different people's opinions because I don't think that we know. I really don't. And I always like to see what this research, you know, I haven't looked into how the tar receptors affect it. I know that they bind it, but that's something I will definitely look into. And I appreciate you giving this talk.
Yeah, no, I think the thing is we still don't understand a lot about TAR1. It's kind of the new kid in the block in a lot of ways when it comes to psychiatry. Obviously, with the TAR1 agonist, right, coming out soon, hopefully for schizophrenia. And, you know, again, we don't know how TAR1 agonists work the same way that LSD does in the brain, or is LSD doing something completely different, and what effects that has. And we do know, it's from what I understand, the TAR1 agonists have more positive effects on negative symptoms in schizophrenia. And that says something, right? That if that means that's pro-cognitive in a way. And if you're having something that's pro-cognitive, that says, you know, maybe that's another effect that psychedelics are having on your brain because they're activating pro-cognitive receptors, which maybe helps with the long-lasting effects from psychedelics. The other thing that there's research showing that psychedelics actually stimulate neuroplasticity, and that may be coming from TAR1 as well. So that kind of goes back more into why psychedelics work for therapy, is because you're having something that one doesn't destroy, it can destroy, but reduces your ego, so you can have more effective therapy. And two, maybe improving neuroplasticity so that the effects from therapy stay along longer afterwards.
It is very fascinating, you know. And there's something. Have you heard of the TrkB receptor?
No, yes, I have.
I'll find this and post it in the chat. There's a recent article that's been circulating that came out of Europe that postulates that this specific BDNF tyrosine kinase B receptor, the nickname's TrkB, and people kept saying TrkB, and I was like, I have no idea what the heck that is. But there's a thought that has a role in neuroplasticity, and it's interesting because it directly can be bound by hallucinogenics, but ketamine through its indirect mechanism on glutamate can cause it, and TMS, it looks like the common pathway for neuroplasticity. I don't see anyone who is actually putting together that all the mechanisms work through it, but it's clear it's implicated in all individual studies. And this is something I think Dr. Roger McIntyre is making new hallucinogenics for. He has a private company he does, but it's interesting. I'll send the article. It's well worth reading. I thought it was really good.